Hi all. So I'm Martina Fonseca and I'm an analyst at NHS England, and I'm here to talk today about digital inclusion and specifically the use of GP online services characterized by demographics and clinical factors. So this started more as a project to build internal evidence bases around digital inclusion and also customer experience around the use of mainly GP online services. So the three types of questions we were interested in is who uses these GP online services, which groups might be excluded, and then how the characteristics like sociodemographics, clinical history, or other contextuals like internet speed affect this use. And the third was a bit more of a, can we create clusters or pen portraits of how people use these services? We mainly use the GP patient survey. We used the one that was the latest available at the time, which was the 2021 at-row level. So this is more than 800,000 responses sampled from across the general population in England. The main question we were interested in terms of outcome is the one there on the right, which is which of the following services have you used in the last 12 months? So it's a multiple choice, and it asks in terms of online services around booking appointments, repeat prescriptions, accessing medical records, and how they use online consultation or appointments, or none of those. Now, the context of this is two lenses. There's a whole question around customer experience. So since the long-term plan, but also in more recent publications, there's a talk about putting the patient at the center of their care and the role that digital tools can have in that. But obviously, there's also the lens of digital inclusion. So how do we make sure that we take everyone along that journey? And for some, that might be a digital tool. For others, there might be other alternatives to access or interact with those services. So why the GP patient survey? Well, we do have a range of data sets. We have the GP appointment book, which has something around video and online, although needing improvement. There's patient online management. There's internally more information about the NHS app, but actually typically either demographics aren't included in that, or it's not that easily accessible to link. So actually the GP patient survey, though being self-reported, if you think of the domains of clinical history, social demographics, health utilization, primary care, and online services, it does cover those. So the aim was really twofold. One is, can we give now to internal stakeholders to build a picture of that inclusion, and also to say, look, once we do have enriched data around whether that's the NHS app or online consultations, if that's the business question and analytical question, these are some of the techniques that we can use. And this is some of the evidence base and also the codes that you can look at. So yeah, in terms of existing segmentations, so you might have some that focus on the health state, like Bridges to Health. Others that focus on different points around demographics, so index of multiple deprivation, mosaic, and some that focus on digital inclusion. So you can see how all these are relevant, but covering different bits. So there's something there around, are these sufficient? Do we need more prescriptive clustering, for instance, for user research and local managers? There's also existing evidence of variation. So for instance, a lot around deprivation gradients and awareness and use of services. And this also can be seen in the patient online management and in the NHS app data. But basically, can we go further in that? So as I said, the approach was twofold. One was, okay, what can we get from the data now? But in some cases, it was, are there other techniques that we can use or say, yes, this would be a good thing to look at if we wanted to get that information? So both from data science, but also public health and management. So in terms of who uses, so that's descriptive statistics. Around the characteristics, we use multivariate logistic regression, but we also looked a bit into, could we use decision trees? Is that more helpful for some users because it creates more comprehensible outputs? In variable importance, is it enough to use stepwise, or could we use something from random forests? And then around creating clusters, we mainly want to look at what do the existing segmentations tell us, but also how could we use data-driven clustering. Today, I'll mainly focus on the logistic regression and existing segmentations, which is the ones that we apply to the full data set, but happy to talk about the use cases where we build the code around some other use cases. Yeah, so on logistic regression, basically we have an outcome variable. So in this case, for instance, use any online service. What we're trying to understand is once you account for other covariates, which are the ones that might relate to that, whilst you're adjusting for other characteristics. So this can help with reducing confounding. So rather than just looking at, are they using a service by, do they have a long-term condition? Is that still true if you adjust for age, gender? Well, this isn't causation. This does allow you to really detangle some of the other factors. And also, when you have such rich data sets, even though you could obviously leverage a dashboard or others, it just provides a neater way to try to understand where the variation is appearing in your data. So then we use forest plots to show this. So essentially in logistic regression, you get the odds of an outcome. So in this case, the outcome is, have they used any online service? And here I just have two covariates, so smoker, which has 4 statuses, and has shielded, so that relates to COVID. Then you get an odds ratio in relation to the reference. So if it's above 1, it's a higher odds. So for instance, former smokers have a higher odds than those that never smoked, and it's about 8% higher. The asterisk and the fact that the bars don't overlap the odds ratio equals 1 indicate the significance in those examples. Well, for instance, the occasional smoker is at a lower odds of about 22%. So that is the interpretation. Now, in fact, we did this for initial was 5 models, so the outcome variable differs there. So any online service and then the individual online services. And so I'll mainly be showing the one in green. But then you could think in some cases you want to know just in general who is using the online service. But in others you might say, well, okay, but what actually happens, there is a need, and given the need, did they go the digital route or not? So obviously we're not linking here to others, but there is some information within the survey around have they used a service. So if I, for instance, say online consultation or booking an appointment online, there are some questions around, have they booked any appointments in the last 12 months, or have they attended that? So that you could look at that model and say, okay, these people have attended, so were they offered and or preferred to go via a digital route? Yeah. So this is just that first model. So have they used any online service? So we use the full sample rather than those that have interacted. So it's mainly 3 types of variables. So the demographics, so their gender, their age, their working status, their carer status. In terms of clinical, for instance, there was a smoker status, 17 individual long-term conditions. Again, this is self-reported. And then some contextuals around deprivation, the internet speed in the area, and whether these GP practices were enabled for the services. So yeah, there's a lot going on here, but essentially this is the first bit that's around sociodemographics. And so what we can see here is, for instance, that in this case, being male, being Black, or for instance, certain age groups. So as you go to much older age groups, those 85 and older, 75 and older, you get much lower odds of having used an online service. And a lot of these patterns are the same if you just consider that other model of those that had the need to interact with the health service. Same with worker status, those who are permanently disabled, permanently sick or disabled or unemployed have lower odds. And maybe as expected, those were carers and guardians who are more interacting with these services. Thank you. So in terms of clinical conditions, maybe as expected, a lot of them are associated with higher odds. The notable ones on lower odds are those with a history of learning disability, blindness, and also history of stroke. Also, regular and occasional smokers were interacting less with these services, and the ones that were most were those that were former smokers. In terms of the ones that were associated with higher use, just in terms of the odds, we see their mental health, neurological, hypertension, respiratory. This is just a hypothesis, but for some of these, there's a lot of regular checkups and online consultation forms. So for instance, asthma. For some others, there's self-referral. So that might be explaining some of those, but that would need further user research. And then again, on the contextuals, I think the most striking is you can see there, even after correcting all the others, you see there the deprivation gradient. So 10 is the least deprived. So there you see about almost 50% higher odds of the least deprived using these services. Also those practices in urban areas or with more patients. And again, not surprisingly, this following year in the practice where more patients are enabled to use online services, you get higher use of those services. Actually, what we showed in the others was the magnitude, but not importance. So this is just saying in the model where we had a single round around long-term conditions, you can see the most relevant factors there. So long-term conditions, age, their enablement, and deprivation. If you unfold that to a model, that was actually the one we've seen before in terms of individual conditions. You can see there hypertension, mental health, and breathing conditions like asthma. And I'd say overall, though there's some variation, you see a similar picture. So for instance, in orange is the deprivation decile, it is always high up there, and age and the enablement of the services. So yes, I'll skip through this, but basically we found similar things when using decision trees, mainly around long-term conditions and age and their smoker status, for instance, and just making a more explainable potentially model to use with local systems. The final thing I just want to highlight was around one of the other segmentations. So deprivation for all the individual services, you had quite a stark gradient. But another one that's quite interesting that's out there, it's from the Consumer Data Research Center, and they basically tried a lower super output area to find 9 clusters of how people use the internet. So it includes the internet survey from ONS and other data, and it's mainly in the order of decreasing engagement. So he said, okay, how does this look like if we map it against what we've seen in the GP patient survey? So actually for online consultations and medical records, it maps quite, there's a good correlation there, disengagement and lower use of those services. So you can say this is a relevant segmentation to use. If you go to booked appointments, you actually get 2 groups there, and where you get more mixed pictures on repeat prescriptions, which might be, again, because of that, actually it's the need and then the use of digital given the need that might be confounding it. And actually repeat prescriptions was at the time the service that was most rolled out. So you could say there's more variation in the early adoption and that might fade away. So yes, but you could also say that there's a case that you might need other segmentations and it might be more useful for a local service to do their own clustering based on various dimensions to find 6 or 7 groups. And the advantage of that is also you're not just looking at one outcome variable. You might be looking at various online services and saying, well, this type of patients, so the ones that are guardians, use more online consultations, but use less prescriptions and so forth. So yes, to finalize, so in this piece, we basically looked at insights of dimensions of digital inclusion and different groups of users. We tried to more lay the case not only in terms of the insights, but different techniques that can allow us to understand better how people use different online services. And especially once you get to developing local insight, it can be very useful allied with user research. Thank you.
Thank you, Dr. And we've got maybe a minute or 2 minutes left, maybe one question. Quick on, there you go, it got my eye quickly.
Curious, smokers, like my dad, would be prime audience for using this because it doesn't have to go to GP, but they didn't use it. That's right. Smokers just rejected digital.
Well, yes. So I'm not sure. I do think possibly, again, this is just hypothesis, for former smokers, they might have maybe better self-efficacy. Maybe they're more involved in their health, or maybe there's some kind of apps or monitoring that is there. Again, this is just a hypothesis. Yeah, I was a bit surprised as well, because I would have thought that maybe because they have higher utilization, that they might have appeared as using those more. But yeah, so that might be one of those that would be good to do some local digging on. But, yeah.
You managed a little flint, go on,
Yeah.
tiny question.
Just sort of related, was there anything in the survey included the question of having used a GP in general? Just because, again, I might imagine just smokers avoid GPs, and that against the reason.
Yeah, so definitely there is a question, have you booked an appointment in the last 12 months, have you attended one, so that you can, so for those models we did that, and you would still see smokers as using less, even if you only consider those that did attend an appointment in the last 12 months. For prescriptions, it's a lot harder because there's no question they're asking them explicitly if they're using repeat prescriptions.